Okay. Can folks see that? Okay. And then Lindsay, yeah, if you can just keep an eye on the waiting room and let anybody in who shows up. So hello, everybody. Thank you for joining us today. I'm Karen Burns, and I'm joined by Holly Crone. We are both program managers within the Department of Perinatal Psychiatry at UNC. And we're here today to share a little with you about perinatal mood and anxiety disorders and how you can help direct your patients to care through two programs at UNC that are designed to support you in this area. So we'll go ahead and get started. So we'll start with a little bit about perinatal mood. When we think of mental health during this time, many of us think of postpartum depression, but we've moved toward a more inclusive term over the years, perinatal mood and anxiety disorders. Advocates for maternal mental health have encouraged this language because for many women, depression isn't what they connect with, but they are experiencing quite a bit of anxiety. And we've learned also that anxiety in the third trimester of pregnancy is much more common than we thought. So perinatal mood or anxiety disorders, or PMADS, is an umbrella term covering a range of symptoms from depression and anxiety to postpartum psychosis. It's a helpful term because it's inclusive mix of symptoms. It is an inclusive mix of symptoms that a patient might present with. When thinking about risk factors for PMADS, it's important to go back to the idea of basically just mental health being an important part of whole person care. The risk factors go across biological and social factors. So trauma, family history, substance use history, socioeconomic status, and so on. In that sense, it makes it challenging to predict who will ultimately experience a perinatal mood disorder. Even with all of the risk factors we've known about for many years, we can't really predict who will have an episode because there are so many interactions at play. So it's important as a population to know the things that we can do to decrease risk and increase support for women. PMADS are the most common complication during and after pregnancy. Certain populations are at higher risk. So for example, pregnant teenagers or women of low socioeconomic status. The symptoms can last for about 6 months, but for some they last much longer, or the symptoms can appear much later in the postpartum period than we might expect. So for example, one of the triggers is weaning from breastfeeding. Some people wean their children when they're 2 years old or older, and we could still consider that to be postpartum depression because the biological and hormonal components are similar to what we would see in depression that occurs more immediately postpartum. I like to mention this because sometimes mental health, this piece gets relegated to the OB as their responsibility to be addressed during prenatal care and maybe the 6-week postpartum visit, but then that's it. And the truth is that these women are interacting with pediatricians, family medicine, internal medicine, and others well after their pregnancy, and they might be struggling. So it's helpful for any primary care provider to be aware of this possibility. Of course, COVID in some ways has presented an opportunity to talk with women about their mental health because it's given us a chance to talk about stress. And some people are much more comfortable using language around stress compared to anxiety or depression, which might have some stigma attached. So it gives us some language to use. We all understand that people are feeling very increased stress currently, and it feels more acceptable to talk about that in a lot of ways. Maybe COVID isn't the immediate stressor for your patient. Maybe there are other things going on in her life that are causing her stress or worry. It could be general concerns about getting other basic needs met: food, housing, childcare, transportation, medical costs, maybe the relationship with the father of the baby, and so on. So before we discuss screening and referral, we want to make it clear that there is no benefit to delaying or avoiding treatment for women who are experiencing mental illness during pregnancy. Pregnancy is not protective. The research literature has debunked that myth. We know that someone who is depressed during pregnancy is more likely someone who is depressed during pregnancy is likely to get more depressed during her postpartum period. Similarly, with anxiety or mania or psychosis experienced during pregnancy, it's likely that will get worse postpartum. So not treating it is extraordinarily unhelpful. It puts both the mother and the baby at risk for a variety of things, at worst, suicide or infanticide. So when we see it, we have to treat it. There have been a lot of conversations over the years around the risk-benefit ratio of treating pregnant women with medications. we have to try and pick the treatment options that are going to be the safest, knowing that there's never a zero risk situation. Not treating postpartum may result in difficulties with lactation, worsened attachment, bonding, worse neurodevelopmental outcomes long-term, affect dysregulation in the child, and a poor mental health trajectory for the child, such as later risk of ADHD, suicide, and ultimately adverse consequences on the family unit. So the key take-home message today is that not treating perinatal mood disorders is bad for mom, bad for baby, bad for the family. And this is from a study authored by Dr. Elizabeth Cox and others at UNC. She's currently a perinatal psychiatrist at Wake Med North. And this is data from UNC from about 4 years ago, and it shows that there's just still huge room for improvement even at UNC. In her study, about half of patients at UNC with perinatal depression were identified. A much smaller percentage receive treatment, and then the number that actually receive adequate treatment and achieve remission is very small. So this should help us to realize that depression screening and treatment is not where we would like it to be at our institution. There are multiple opportunities to improve perinatal and postpartum care. One is in appropriate iterative screening and follow-up screening through the perinatal and postpartum periods. Okay, so when should you screen your perinatal patients for mental health and substance use concerns? This is a very tricky question because recommendations vary across professional societies. The ACOG recommends that OB providers screen patients at least once during the prenatal period for depression and anxiety using a standardized validated tool. And they also recommend that OB providers provide a full mood assessment during the postpartum visit. WISPI, the Women's Preventive Services Initiative, just came out with recommendations this summer, recommending anxiety screening in adolescent and adult women, including those who are pregnant and postpartum. They don't provide any guidelines around specific screening intervals. They suggest that clinicians use their best judgment to determine frequency. And finally, the American Academy of Pediatrics recommends routine screening for postpartum depression at the well child visits at 1, 2, 4, and 6 months. Ultimately, we believe testing should be continuous and iterative across all 4 trimesters of prenatal and postpartum care. We think best practice is to screen at the initial prenatal visit, and then at least once in the 2nd and 3rd trimester, and then following the AAP at 1, 2, 4, and 6 months postpartum. That seems like a lot, but there are several good reasons to think through how to make that work in your practice. Incorporating mental health screening into your prenatal and postpartum visits normalizes the process of screening, it reduces stigma, and it really opens the door for conversation around mental wellness with your patients. So when you screen at the initial prenatal visit, you have baseline data, and you can compare that to how your patient is doing over time. Like I said, anxiety can peak in the 3rd trimester, but you might not notice if you don't have data from earlier in the pregnancy. So this ensures that the process takes a preventative approach to mental wellness as opposed to a reactive one. And of course, we know that mental health and physical health are directly related, and care for one must be reciprocated in the other. All right, so some questions to consider. We won't go through these today because we don't have time, but I just want you to think about how your practice is currently operating and where there might be room to improve. So if you see pregnant and postpartum women in your practice, are you screening them for depression or anxiety or substance use? What tools are you using, and when are you using them? Where are you tracking it? Are you putting it in a flow sheet so that it can kind of be easily accessed later? Or, we're pulling a lot of data out of Epic right now, and a lot of this screening data is kind of buried in the notes, in assessment notes and visit notes, so they're hard to find, which I imagine makes them hard for you to find for reference later. So who's documenting and reviewing this data? What happens when a woman has a positive screen or says something that you find concerning? Who in your clinic is responsible for connecting her to care, and who's going to follow up and make sure that she connected with an appropriate provider? So all big questions that we cannot tackle today, but I do want to share with you as we kind of go through our presentation. So I'm going to turn it over in a second to Holly Crone. Really the purpose of today's presentation is to get you thinking about perinatal mood, but also to let you know about 2 programs at UNC that can help you today with any patients who need help with access to care. This is a very simplified little flowchart, but generally there are supports for you around therapy, medication management, and psychiatry options for your patients at UNC. We're going to start with Summit, so I'm going to turn it over to Holly.
Hi, all. We're so glad that so many of you could join us today. And I'm going to be talking a little bit about a pretty exciting research study we're conducting in the departments of psychiatry and OBGYN to offer psychotherapy to pregnant and postpartum patients who may be experiencing depression in the perinatal period. So, this is a study, it's a 5-year multi-site study, so we're working with partners at the University of Toronto in Canada and the North Shore Hospital System in Chicago. And we're really interested in exploring how psychotherapy can be delivered to treat perinatal depression and who can deliver it. And these questions are coming out of the known barriers that women have to accessing mental health treatment. It's very difficult to come to in-person appointments at times when you're pregnant, have other kids, when you're postpartum with a new baby. And there's a lack of mental health providers in many areas in general and specifically for perinatal mental health. So we're looking at whether or not psychotherapy can be delivered as effectively through telemedicine as in-person visits. And this has been very interesting in the context of COVID because we have essentially moved entirely to telemedicine once the pandemic hit, but this has afforded us an opportunity to have a much larger reach for the study and offer this service to basically like patients across the whole state if needed through referrals and any UNC OBGYN sites. And so the other thing we're looking at with this study is who can effectively deliver psychotherapy treatment. We have a team of trained perinatal psychiatry providers that include social workers, clinical psychologists, and psychiatrists. But we're really interested in learning whether or not trained nurses can deliver psychotherapy for this population. And so we've recruited a group of mostly their L&D inpatient floor nurses who've gone through an extensive training to deliver this specific type of therapy and are seeing patients via telemedicine with the current system that we have. Next slide, please. So this is just to show you our shining faces of those who are running the study. Our principal investigator is Samantha Meltzer-Brody, who's now the chair of the Department of Psychiatry. We're partnered with Dr. Allison Stubbe and OBGYN, have a fabulous team of clinical psychologists, Crystal Schiller and Malin Reyes Rodriguez, who specializes in Latina health and is offering services to our Spanish-speaking population. So this study is available for both English and Spanish-speaking patients. We collaboratively run this study through psychiatry and OB and have another clinical psychologist who helps us out. Next slide, please. And so the specific type of therapy that we're delivering is an evidence-based therapy called behavioral activation that we think partners really well with the perinatal period. And its focus is on increasing enjoyable or fulfilling activities for those who are feeling depressed and anxious that align with one's values to sort of get them back on track to where they would like to be during this period. And just as a little show of kind of uptake for therapy. They've done surveys of treatment preference among pregnant women, and we can see really high numbers here, upwards of 90% of those who would engage in individual therapy, and that was a big impetus for running this study. Next slide, please. So as I mentioned before, we were able to fairly seamlessly transition to offering telemedicine only treatment because of COVID. We're accepting referrals both from within the UNC system and any practices that are getting sort of outside referrals, they can also be sent to us. The gist of the study is basically an 8-week treatment period where patients will meet with their providers, whether it's a nurse or one of our perinatal providers, once a week for an hour to participate in the therapy for 8 weeks. And then we do follow them up to a year afterwards to get more information on how they're doing after the intervention is done. Next slide, please. So this isn't anything that really you need to pay too much attention to, but just to give a brief idea of like who is eligible for this study. They do need to be 18 years or older, pretty much the entire pregnancy or up to about 6 months postpartum is when women are eligible to enroll in the study. We are accepting English or Spanish speaking patients. And they do have to have an EPDS score of 10 or above, but we will screen them for that. And then 2 of our main exclusions are just active substance abuse, in which case you could refer them to Horizons, and any symptoms of psychosis or mania, although you probably should still refer them to psychiatry, and we'll just treat them through a different method. So one of the really nice things for the patient population about this study is that women will either be randomized to receive sort of standard treatment with members of our psychiatry team, meaning their visits will be charged to insurance just like regular care, or if they get randomized to therapy with our trained nurses, the care is free. And so that's a big benefit to this study, is the opportunity for women to receive free care. Next slide, please. And so to refer to this study, and you don't have to really remember any of the eligibility criteria, would be to just send a referral to our outpatient clinic, which is the UNC Psychiatry Outpatient Clinic at Vilcom Center. You can add a comment that says, you know, perinatal psychiatry or summit study, and they will be screened through our review process. And then this is our study contact info. And I do see the 2 chats that have come up, so I will just answer these while we're still here. So patients who do not have insurance are able to participate. We do counsel them beforehand that they may get randomized to the standard care group, in which case they can drop out of the study, talk to a financial counselor, or we can help them apply for charity care, basically. And so we have had uninsured participants in the study, some paired with the specialist team and some paired with the nurses for free care. And we can accept referrals from anyone. So if you have a pediatrician who has identified a mom who might need services, you can basically, if you can't place a referral through Epic, you can send us an email at this contact information.
I'm just showing the referral page one more time in case anyone wants to make a note of that. But we can share the slides afterward as well. Thanks, Holly. Okay, so I'm going to tell you a little bit about NC Matters before we wrap up. So NC Matters is about 2 years old, and it is a not a therapy program. It is a provider-facing consultation service. So you can kind of think about it as a more structured and timely curbside consult. We provide a lot of training and technical assistance to providers around the state on the topics of perinatal mood disorders and screening. But the engine of our program is really the consultation line. So anybody can call the line: doctors, nurses, PAs, social workers, therapists, lactation consultants, pediatrician, anybody who is working with a pregnant or postpartum woman. We're loose on postpartum. It can be a year or more, or maybe a woman who is trying to get pregnant. We're pretty easy there. You can call the line and you can speak with an LCSW or a psychiatric provider right away to answer your questions about treatment and care. So our goal is to keep the patient in her medical home to the extent that it is possible. I can't tell you how many referrals perinatal psychiatry gets for patients who don't know that they were referred in the first place, or don't really want to see a therapist or a psychiatrist, or aren't sure they want medication. So in many cases, patients do want care, but they are hoping to get treatment in the place where they're already comfortable, if that's possible. And, we don't have integrated behavioral health across UNC. So our mission is to help you support your patients where it's feasible to do so. We know that doctors have a lot of concerns about managing psychiatric medications for patients, especially if they're pregnant or postpartum. But most patients can have their medications safely monitored in a primary care setting with psychiatric consultation. So we are here to help you in that area. And like Holly said, medication is not right or desired for everyone. So we also have a great resource and referral specialist who can help connect the patient to other appropriate care options in her community. So again, we help around diagnoses, clarifying questions around medication management and care planning, and then just directing to resource and referral. Of course, we do get calls about more complex patients with, co-occurring disorders and complex psychiatric histories. In those cases, we will offer a one-time psychiatric assessment for the patient with a UNC provider. The provider, of course, who calls the line will need to understand that this is a consultation for the purposes of just providing more information. So we don't prescribe to patients and we don't take over care. We might refer them into UNC for continued therapy and treatment if there's an opening, but the psychiatrist who sees your patient through NC Matters will not necessarily become her psychiatrist on an ongoing basis. So we see the patient, we do a full psychiatric assessment, we will share it with you in Epic, and then our LCSW will follow up with helping you connect the patient with the resources that the psychiatrist recommends, whether that's community-based therapy, medication management, support groups, whatever the case might be. If managing the patient's ongoing care is not within your scope of practice, if you're her pediatrician, her child's pediatrician, or if maybe you're doing a one-time MFM consult and you're not going to see her again, that's fine. You can still call, but we'll just want to talk with you and the patient about who's going to continue her care after the psychiatrist sees her. We don't want to leave her hanging with nowhere to go. Just a little information about our program. We've done 168 phone consultations since November and 28 psychiatric assessments. 97% of providers who have called our line report being satisfied or very satisfied with our services. And this is the most important one, I think. 84% of providers reported that consulting with us reduced the patient's need for a higher level of psychiatric care. So that might mean going to a psychiatrist, but we've also been able to avoid some unnecessary trips to the emergency department. So please call us. We have been able to serve patients from 25 counties. We're kind of targeting, in terms of outreach, we're targeting kind of the perimeter around the triangle, but we serve any practice, any patient across the state. Here's our care team. Our care coordinator our line is staffed full-time by 3 social workers. So myself, Carolina Alford, who is embedded in the OB clinic at UNC Chapel Hill, and Joanna Contreras, she's a licensed social worker at Duke. And then here is our psychiatry team at the bottom here. You might recognize Rebecca, Liz, Mary, Susan, or Anne. They are all practicing clinicians within the UNC system. And then Marla Wald is a perinatal psychiatrist at Duke. Here's our access line number. It's, like I said, it's staffed Monday through Friday, 8 to 5. If you call after 5, you can leave a voicemail. We'll call you back the next day. If you don't have time to make a phone call, you can, UNC folks can send an in-basket. You can send it to me, or you can send it to Carolina Alford. I think our locations are both outpatient psychiatry at Vilcom. We'll respond to you within 24 hours, so feel free to forward us the patient chart and ask your question. We can schedule a time to call you back. We have a lot of providers who will call us anticipating a patient visit if they kind of want to run some things by us before they see the patient again, or if they want us to try to catch the patient while she's in the clinic. So if you're anticipating a visit and you want us to try to connect with her while she's physically there, you can, again, send us an in-basket or call us and we can try to make that happen for you. I'll mention we do not give resources directly to patients without first speaking to their providers. So we ask that you not give our line to patients directly. We ask that you call us and then we'll loop back with supports. Here's our email address and again, our consult line number and our website. Feel free to check those out. And that is, that's all we have for you today. We wanted to keep it short. I did want to see if anyone else had questions about either of the services or about any resources around perinatal psychiatry. I don't have it listed here, but I do want to, I'll stop sharing my screen. I do want to make sure that I mention Postpartum Support International, which is a great resource for patients. They have a warm line and a text line that patients can call 24/7 or text 24/7. They can speak with someone directly and they have a wealth of virtual support groups. They can help connect patients to therapy. So if you've got a patient who's pretty comfortable taking things into her own hands to try to seek care for herself, I highly recommend postpartum.net. And if I would be happy to Google that number and I will tell you, what it is. Okay, so the number is, I'm actually, let me see if I can share my screen. Since we're recording. There it is. Okay, hopefully folks can see that. The number for PSI is 1-800-944-4773. It's an English and Spanish line, and then the text line information is at the bottom. This is a great website to share with patients. Okay, any other questions? Okay, doesn't look like it. Well, thank you all for your time today. If you do have questions, we'll hang out for a few minutes and answer them. I will stop recording.